Stage is yours, Elisa.
Okay. Good evening to everyone. First of all, I would like to thank the European Shoulder and Elbow Society for the award and for the invitation to participate to this meeting, and also to thank all the team that has participated to the study, and a special thanks to Carlos Torrens to making me join to his projects. So in the conservative treatment of proximal humeral fracture, it's common practice to perform a 1-week X-ray control in order to detect further displacement of the fracture that may require surgery. Only one published study assesses the need of periodic imaging studies in patients with non-displaced fractures, with no evidence that it results in a change of treatment, and concluding that it isn't necessary in most patients. To date, no studies have been performed in displaced fractures treated conservatively. So the aim of our study was to evaluate the need for 1-week X-ray control in patients with proximal humeral fractures treated conservatively for all fracture types, displaced and non-displaced. We hypothesized that a 1-week follow-up control would not confer any advantage in the treatment of this fracture. So we perform a prospective randomized multicentric study involving 4 centers, including patients from February to November 2021. We include patients aged from 18 to 85 with an acute proximal humeral fracture, less than 1 week, candidates for conservative treatment, and with no previous shoulder pathology. And we excluded patients with dementia, patients unable to participate in a rehabilitation program, and candidates for surgery. I'm sorry. The treatment decision was undertaken in each center under the shoulder surgeon decision according to age, comorbidities, functional demand, and the near fracture pattern according to an X-ray and a CT scan performed the same day of the fracture. We aim to include 90 patients in order to detect a minimal clinical important difference of 10 points in the constant score. At the end, we included 143 that were randomized into groups. Group 1 received a 1-week X-ray control, and Group 2 without a 1-week X-ray control. All patients follow the same treatment, were immobilized with an sling for 3 weeks, and then they follow the same rehabilitation program. Radiologically, patients were followed up with simple X-ray in 2 views at 1 week for Group 1 and at 3 months, 6 months, and 1 year for both groups. Pain was assessed with the BASA scale at 1 week, 3 weeks, 3 months, and 6 months. And the functional outcomes were assessed with the constant score and the simple shoulder test at 6 months and 1 year. As complications, we assessed non-union, stiffness, avascular necrosis of the humeral head, and the need for surgical treatment. And we also recorded the need for 1-week X-ray control in patients in Group 2. Let's move on to the results. We had a loss of 16% rate of follow-up, less than the 20% than we initially estimated, most of the cases due to unknown reasons. And at the end of follow-up at 1 year, we had 120 patients, 66 in Group 1 and 54 in Group 2. Both groups were comparable in terms of age, gender, laterality, dominance, and fracture type. And regarding the fracture type, we had 36% of patients that had a 1-part fracture, and it's important to highlight that we had 64% of the patients that had a displaced fracture according to the new classification. Regarding pain, no differences, statistical differences were observed between groups at any point of follow-up. And in the functional results, no differences were observed in the constant score and in the simple shoulder test at 6 months, and neither at 1 year, with 70 points in the constant score for both groups at the end of follow-up. Moreover, there were no differences in the constant score subscales between both groups. And regarding the complications, we recorded 5.6% of complications without differences between the groups. 5 patients in Group 1, 2 cases with stiffness, 2 avascular necrosis and stiffness, and 1 avascular necrosis. In these groups, 2 patients required surgery. And in Group 2, 2 cases of stiffness and 1 non-union. No patient in this group required surgery, and 1 patient received a 1-week X-ray control without changes in the treatment protocol. So according to our results, we can suggest that a 1-week control X-ray is not necessary in proximal humeral fractures treated conservatively. Thank you for your attention.
Thank you, Dr. Cassart. And as our program, I would like to invite Dr. Karl Wieser as our peer for the comments about this presentation.
Yes. So first of all, I have to say thanks a lot for this very kind initiative and the invitation. I think it's very interesting to do webinars like this on such high-ranked papers. I really need to congratulate both of the authors and all the other authors actually for this super nice studies. Elisa, to your study. Unfortunately, I didn't have the chance to really review a full text manuscript, as I just figured out that it's not published yet. And but you were kind enough to send me a PDF of the presentation. I looked through it and tried to get some information out of it. I think regarding methodology, it's clear this is prospective randomized trial should be considered as a level 1 study, obviously. Regarding the clinical relevance, I think the relevance is, I would say, moderate to high, as it doesn't really affect our decision making. So it doesn't really give us some advice about should we treat operatively or conservatively, but it affects our daily practice and how we can or should treat our conservative treated patients. It gives us the opportunity to save money and make this treatment actually more efficient for ourselves and also for our patients. It's my job to highlight a little bit not only the nice presentation, the nice research you showed, but also a little bit the limitations of the study. And as you have shown, the groups are really comparable. There were no significant difference in the demographics and also not in the fracture pattern. However, I think there's a little, maybe you need to clarify a little bit more the indications for surgery versus conservative treatment. It's somehow kind of vague, and as you said, it's kind of surgeon's decision on variable points, but it's not clear that which fracture pattern really went to surgery, which not, and what was really the indication for the conservative treatment. Also, maybe we can discuss this all later on. Okay. There was also one point which I was actually really interested in, and I didn't find on the slides, is the number and the rate of secondary displacement you saw in the first group. So you have one group where I did the 1 week X-rays. We have at this point no idea if there was any secondary displacement, if it was just not enough to indicate surgery or whatever, or maybe there was no secondary displacement at all. So maybe you can comment on that later on. And finally, I think the number lost to follow-up, although you said you expected 20%, which I think for 1 year follow-up is quite high. So I think this is something which has a little flaw, especially in the second group without X-ray control. The number which dropped out is 16 out of 70. This is actually, I think, more than 20%. And this actually makes your findings a little bit less robust. So the fragility index of this study is kind of a little high, I think, with that, because just, I don't have the statistics for that, but if 2 or 3 out of these patients would have needed early surgical intervention, the result of the whole study would actually be completely different, and the conclusion of the study would be different. So I think we cannot really ignore this over 20% loss to follow-up. Nevertheless, I really want to congratulate you and your others for this nice prospective randomized trial, which definitely has the potential of changing our current practice. And this is actually, unfortunately, not common for our everyday published papers and literature we can read. I think maybe it's 2 or 3 questions I mentioned already, 1 or 2. So the secondary displacement rate I would be interested in. Maybe a little bias of the surgeon. I don't know if the not the surgeons, so the treating physicians were blinded. Most likely not, because they have seen a 1-year X-ray or not. So is there some bias in their decision to treat patients the secondary surgery or not? And you showed constant score of 70 points, which is, I think, fairly okay. The question is if you would say that this is really satisfying for this conservative treated patient, or if you think this might be higher if you would have treated some of them operatively. I think that's my comments, and I really want to congratulate you.
Okay. Regarding the indications of surgery or conservative, this could be one of the limitations of the study, because it's true that the indication for surgery or conservative was undertaken in each center, and this could have created little different populations in the 4 centers. But it's the reality. We don't have, we still have a lack of a consensus or an homogeneous or objective criteria of which patients with a proximal humeral fracture has to go to the surgery or to the conservative. We decide the treatment decision, in my opinion, in proximal humeral fracture is a shared decision with the patient that depends on a lot of factors. Depends on the fracture type, of course, but depends of the comorbidities, the functional demand, the expectations of the patient, the family, the family support, the social situation. So it's true that the decision depends on a lot of factors, and we do it in our centers that always the shoulder surgeon decides the treatment, taking into account all these factors. So it's very difficult in a study to do an homogeneous criteria and objective to include the patients. But I think it gives external validity to the study, because it's the reality in the treatment decision in proximal humeral fractures. So I agree with you, that could be a limitation how we decide a conservative or a surgical treatment. But I think it's our reality. It's not easy to decide a treatment in a proximal humeral fracture, taking into account all the factors. And regarding the secondary displacement, we didn't assess the secondary displacement. The objective, our hypothesis was that we always perform a lot of X-rays at 1 week, at 3 weeks, at 8 weeks, in order to detect a secondary displacement and change to a surgical treatment. But our hypothesis was that we never change, nearly never change to a surgical treatment. So we thought that if the secondary displacement was relevant, it would be reflected in the results, because we have 2 populations in same fractures, comparable groups, and the only differences between them it's to have or not to have an X-ray. So if if we don't change the treatment in any patient, in any group, we have the same functional results and we have the same number of complications, what happens in the X-ray, perhaps we have secondary displacement, but probably it's not enough relevant, because that's not influence in the results. So we didn't assess the secondary displacement in the X-ray. And in addition, I think it's not easy to assess radiologically. It's not as easy as it seems to assess in X-ray the secondary displacement in the follow-up, because the X-ray that we have in the emergency are different, and it has been published that little differences in the beam can give you different patterns. So we think that we don't have to follow up the patients radiologically if the patient is going well. And for this reason, we didn't assess the displacement. And the other one, I don't know the question. We were not blinded.
Maybe the bias of the treating physician, as I think you had a clear purpose what the outcome of the study will be, as you said, because you know that you never change your treatment. And there might be a little confirmation bias in this, that you know that these patients were included in this study and you know what you want to show with this study. So maybe that
can be. I agree, can be, but we assess the groups and we assess if we change. So it can be a bias. I agree, but it's 4 centers, so and a lot of people participating in the study. But this was a hypothesis that we don't need the follow-up. Can be. I agree.
Actually, Karl asked. Yeah, okay.
Sorry, just if you would take this further, you might also be able to say that the 6 weeks control is not necessary and the 3 months control is not necessary. You know, it's not that.
We are not saying this. Our results show that this X-ray follow-up doesn't provide any advantage in the treatment when you have decided the treatment. The question is that you have decided. The point is that you have decided the treatment before, for all the reasons that you have to decide the conservative treatment. So if the patient is going well, if the pain is decreasing, the patient begin with the rehabilitation and the range of movement is improving as you expect for the fracture and for the patient, you don't have to follow up the patient radiologically. You can wait, do a follow-up at 3 months to check the fracture union, or even you cannot do it if the patient is going well. But of course, if you have a patient with pain that is not going well, you have new trauma, you have suspicion of the patient is not going well, you have to do the follow-up. You don't have to avoid all the follow-up to all the patients, but in a big number of patients, you can decrease the number of follow-ups and of checkup visits or complementary explorations and radiation, and you can do it.
I'm just not sure if this bias which I mentioned, that you already decided on day 1 how you want to treat your patients, and then if we look at the outcome of the data, you say, okay, it's 70 points in both groups. Standard deviation is 20 in group 1 and 70 in group 2. So there are some patients who are actually not doing very well. And maybe these patients would have needed surgery or would have, you know, at least be kind of benefited surgery early on to increase this this constant score outcome. You know, you can argue that if you would have been more rigid with your indication, or more flexible with the indication, I would say, and would have undertaken some of them early surgical treatment, whatever, reverse shoulder arthroplasty, plating, or whatever, you might be able to increase the outcome. So
can be, but we have the same results in the other group. The group 1 had the opportunity to change to the surgical treatment because they had a 1-week control, and it was possible to do it. Everybody could order an X-ray if it was considered at any point of the study, and the investigators were allowed to do X-ray, and we recorded. And the group 1 had the opportunity to change, and the constant score is the same. And actually, the patients who had surgery were both from group 1. The patients who had surgery due to a bad result were patients from group 1, not from group 2. But it's possible, the bias.
Okay. Thank you, Karl. You have asked nearly all questions in our minds, but there's also one question from Augustinas. He asks, were there any patients from the first group sent to surgery after first week control? It is not mentioned in the presentation.
No patient go to surgery.
No patient.
Just
Okay.
2 patients at 8 months and at 10 months from group 1 went to surgery. One for a vascular necrosis that was treated with a reverse, and one for stiffness that was treated with an arthroscopic release.
What I wanted to learn is also your age limit is very large, from 18 to 85. So I cannot imagine someone with 20 years old with 4-part fracture, and all these are excluded because they have also already decided for surgery, or
no, the treatment was decided before. So actually, only one patient had a four-part fracture in the sample, and age was not an exclusion criteria to participate, because the decision was done before the treatment. So all patients with a displaced fracture 20 years old were not in conservative treatment, obviously, were in surgical treatment in a displaced fracture. So the people in this sample, young with conservative treatment, probably it's a one part. We cannot do an analysis by age or by fracture type, because the sample need to be more higher. But age was not is not a factor that has been related to a secondary displacement, or gender or fracture type has not been associated with a radiological secondary displacement. So not to be young means that you are going to have more risk to have a secondary displacement. So for this reason, age was not excluded or is wide the range.
Sorry,
Yeah,
Elisa, one more question. Did you, I don't know how it goes in Spain, but at least in Hungary, from medical legal purposes, I think it is not bad to have an X-ray, because if anything goes wrong and the patient later on tells that it was not spotted out at 1 week, 2 weeks, 3 weeks, whatever, then probably the treating doctor can be in trouble. I don't know how it goes in Spain.
The study went to the ethical committee and was approved by the ethical committee before doing the study. So we don't have problems on that way. So the question is that we don't have evidence about this. So we have done. We do follow-up X-rays because we have learning, or someone told us, but we don't do it because we have evidence to do it. So if we have an evidence in our scientific literature, then we have power for legal purposes.
All right, thank you.
Our next presenter will be Stefan Moosmayer from Norway, and he will give us a long time results of his rotator cuff cohort. They have already given us very good insights from years about the rotator cuff tear patients, and this is their last study, and which have won the best national paper prize. Please, Stefan Moosmayer.
Good evening, everyone. I want to express my gratitude to the SECEC for inviting me, and a special thanks to Professor Atalar and Professor Wieser for organizing this webinar. It is my pleasure to present our study titled 15-year results from a randomized comparison study between tendon repair and physiotherapy for small and medium-sized rotator cuff tears. And I would also like to thank all the co-authors listed below for their contributions. Supraspinatus tears are among the most common injuries we encounter in orthopedic clinics. However, treatment selection for these tears is still a matter of debate. Operative and non-operative approaches exist. There are problems related to both procedures. For tendon repair, there are surgery-related complications, such as infection or capsulitis, a risk of non-healing, the long period of rehabilitation, and tendon repair is more expensive than physiotherapy. On the physiotherapy side, the quality of the physiotherapy can vary considerably, and most important, the tendon remains unrepaired. So what do we know about the results from existing comparison studies of the two methods? The 4 studies on this slide have shown similar results for the two methods in the short term, which means at a 1 or 2 year follow-up. Based on these results, a primarily non-operative approach for tears of the supraspinatus is now often recommended. However, there are still concerns. There is uncertainty about the long-term consequences of leaving a tear unrepaired. We may ask if these tears are at risk for anatomical and functional deterioration over time. Or in other words, will an unrepaired tear progress to a tear that is more difficult to treat with a reduced healing potential and a poor prognosis? Several studies of the natural cause of unrepaired rotator cuff tears have shown that tear enlargement over time in up to 50% of patients, as shown in the column to the right of this table. And it has also been shown that tear enlargement is correlated with functional impairment. This leads us to the background of the present study. We hypothesized that long-term results of physiotherapy would be inferior to short-term results, and that this would lead to an increase of differences in favor of tendon repair. We wanted to explore data from the previously unexamined time period of up to 15 years. The study was designed as a randomized trial with two groups, the primary tendon repair group and the physiotherapy group, with optional secondary repair if needed. A blinded assessor performed repeated follow-ups at 6 months, 1, 2, 5, 10, and 15 years. The study population consisted of 103 patients, all with a rotator cuff tear with or without trauma, a tear size of not more than 3 centimeters, a tear location in the supraspinatus tendon with or without a partial involvement of the infraspinatus or subscapularis tendons, and a muscle atrophy not exceeding a grade 2 according to Tomaso. The primary outcome measure was the constant score. Secondary measures included the ACES score, a general health survey, and measurements of range of motion, pain, strength, and patient satisfaction. Tendon repair was performed by a mini-open procedure in combination with an acromioplasty. Biceps tenodesis was performed if pathology of the long head of the biceps was found, and patients followed a standard postoperative rehabilitation regime, including a 5-week period in a sling. Physiotherapy was given at our hospital by 4 shoulder-experienced physiotherapists. Treatment was individually adapted and was given twice weekly with sessions of 50 minutes during the first 12 weeks and with decreasing frequency during the following 6 to 12 weeks. Crossing over from physiotherapy to secondary surgery was possible for patients with no improvement after at least 15 sessions. Statistically, this was handled by intention to treat, which means that the crossovers remained in the physiotherapy group for analysis with their result from surgery. So our results. Follow-up rates were excellent up to 5 years and were still above 80% after 10 and 15 years. The total number of crossovers was 15, which means 30%, with a majority during the first 2 years. This graph shows the result of our primary outcome measure, the constant score. The y-axis shows the constant points and the x-axis the time of follow-up. We see that both treatments resulted in an important improvement from baseline, and after 2 years, the results are close, with a difference of only 3 points. After that, differences increase in favor of tendon repair due to a decline of the result in the physiotherapy group, with the largest difference of 11.8 points after 15 years. A similar pattern is shown on the ACE score, with increasing differences over time, and the largest difference of 15.2 points after 10 years. And also on a VAS scale for pain, we found a similar pattern of increasing differences in favor of tendon repair over time, with a significant difference of 1.8 centimeter at 15 years. There is always the question of clinical relevance of the results. We used the patient acceptable symptom state of 80 points on the constant score reported by Canto as a threshold for a treatment response, which represents a satisfactory result for the patient. In the tendon repair group, 70% achieved this value compared to 43% in the physiotherapy group, which is a significant difference. We further assessed the progression of tear size over 15 years in the physiotherapy group. This table shows the findings of 26 tears that remained unrepaired during the entire follow-up. Tear size increased stepwise from 16.2 millimeter at baseline to 31.6 millimeter at 15 years, and this progress was associated with a decrease of the constant score from 73 to 62 points. Assessment of tear anatomy is also of interest in the tendon repair group. At the 15-year follow-up, we found 27 intact repairs and 16 re-tears. Among the re-tears, 6 were partial thickness re-tears and 10 were full thickness. The difference between the intact repairs and the re-tears on the constant score was 6 points, with a relatively good result of 76 points for the re-tear group. To conclude, from 2 to 15 years, we found increasing between group differences in favor of tendon repair, which were statistically significant and likely represent clinical relevance. Consequently, evaluation of treatment effects for supraspinatus tears should not be based on short to medium-term results only, but long-term follow-ups are needed. Our results may support a primary surgical approach, especially for younger patients with shoulder demands. Thank you.
Thank you, Dr. Moosmayer. And we would like to hear the comments from Karl again.
Yeah, thanks again. I need to say now it's harder to find some flaws in the study. I really need to congratulate you to this very nice study. This actually your patient cohort follows my surgical career over the last, I would say, 10 to 15 years, and I'm now more than happy that the results are actually supporting our doing. Because back then, 13 years ago, when we first saw the 2 years results, I was kind of a little disappointed because it was like kind of what we do maybe didn't really help our patient, but now we see that it helps. But okay, let's start with that. Methodology, I think it's clear. It's a prospective randomized trial, level 1. The power analysis you showed makes sense. 45 patients, 12 constant score points, and the power of 80%, which is absolutely clear. And you still, after 15 years, almost at this point where you still have almost this 45 patients in each group. You have this almost 30% of crossover, and you did an intention to treat analysis, which makes sense, I would say, at least to some point. In the paper and the appendix of the paper, which I would really suggest to everyone to read, not only the paper but also the appendix. You also show the graphs, which you didn't show today, where you really see how strong the influence of this secondary operated patients are in the outcome. And this actually makes the comparison of the data even worse. So those patients who stayed conservatively actually did worse than what you just showed on your graphs. According to the treatment, I think we can consider this still as adequate, although most of us nowadays do arthroscopic surgery. This was performed openly, but I think there's a lot of published data on that functional outcome of open surgery is good. I think especially for the physical therapy, it was quite clear. It was standardized. It was long. It was really some like 3-4 months continuously going on. It's unquestionable that the clinical relevance for us is very high. This is something we shoulder surgeons have every day in our practice, the decision between conservative and operative treatment on rotator cuff tears. As I said, the loss to follow-up, 90% is definitely acceptable after 15 years. So I mentioned before, maybe after 1 year, it's can be not really acceptable, but after 15 years it is. What I was really a little bit when I read the paper, I was actually not astonished, but you had already a little negative selection bias in your operated patients. So what we would consider nowadays as an optimal candidate for surgery, you actually had patients which also kind of negatively influenced maybe the outcome of the surgical patients. There were 44% of really chronic tears. You had all over your group, you had more than 12 months of symptoms. So these are definitely patients who had long-standing rotator cuff tears. There were 13 out of the 52 who had Guttali grade 2. Something is a little special for me and isn't reflected in my cohort, in my patients. You only found 1 out of 52 who had as additional subscapularis tear. I think this might be related to the open approach. I think maybe nowadays with arthroscopic approaches, we might identify a little bit more of the subscap lesions and maybe also treat more of the subscap lesions. And although we can debate about this, if grade 1 or grade 2 subscap lesions really influence, but I think in the long run, they might also negatively influence the outcome of the patients. And what's really interesting is you had 30% of smokers in your repair group, which definitely negatively influence your outcome. I think the key findings, what you showed is clear. The advantage of surgical treatment. I think it's just regarding the constant score, what you showed, successful primary repair ends up with 82 points in the constant score. Also the secondary surgery, most of them performed within 1 year, the same 82 points if I'm not wrong. There was, however, some lost. I think 3 lost at 15 years. It's also interesting that the failed primary repair ended up with 76 points, which is also very good. It's also reflected in the literature. And the physiotherapy only ended with 62 points. So this, what I mentioned, that it's actually quite a big gap between these two groups. And I know that you like and you're interested in the national history of rotator cuff tears, as I am, and it's nice to have a little bit more additional data on this. The increasing tear size of 16 on 11 millimeters after 15 years. We also know this might be on the other side a little. There might be a positive selection bias because, as we know, also from I think from your study as well, that pain is a strong correlator to progressive tear sizes in this conservative treated patients. And as most of the painful patients mostly opted out for secondary surgery, this is actually a positive selected group. And if you just would leave all of them alone, these numbers might be higher. This is also a very interesting finding. So in conclusion, I think this study is best in class. I think there's at this point nothing better which supports us. It is already a very successful and popular study because we cannot neglect the little confirmation bias. Because we orthopedic surgeons, we love research who supports our doing, and this definitely does. And I already use this not only for my presentations. I use your slides more or less daily in my practice. I have it on my laptop. I show it to my patients. You know, you can do conservative treatment. You can go for surgery. Look at the graphs. What do you want to have after 15 years? I think this helps. This helps us really for our daily living. As you said, it supports early surgical treatment for selected patients, especially traumatic and young ones, I think. Also, it supports also stage treatment and delayed surgery if conservative treatment fails after 6 or 12 months. I think we know that we still can go in and do something good for the patients. And as I said, it provides additional valuable information about the national history, so the course of progression of the conservative treated patients. So I really need to congratulate you. It's I think as good as it can be after 15 years, and congrats. It's really nice. Thanks a lot.
Thank you, Karl. Thank you. And there are some questions from the audience. Most of them already answered, but I will repeat some. Did you do subgroup analysis of degenerative versus traumatic tears, Stefan?
Yeah, first of all, thank you very much, Professor Wieser, for your very nice and kind comments. Yeah, we try to do that, but I mean, the power of the study is for 103 patients, and all sub-analysis are based on small groups, so they may generate hypotheses, but they can't really give significant results. We couldn't find differences there. But I must say that the traumatic tears, that was the great majority of the traumatic tears were not really traumatic tears. It were traumatic tears based on a degenerative basis in elderly patients. I mean, 60 years is the mean age of these patients. They have rotator cuffs which are not longer like the rotator cuff in younger people. So there are, I think, in all patients there is a degenerative part in these tears, and I mean, if one really would like to find out if there's a difference, one would have to select the really traumatic tears, which is maybe not so easy because it's a gray zone going from traumatic to degenerative. So it's a difficult thing to do.
And I think it's also questionable if it's really ethical to would include traumatic tears in young patients for a randomized controlled trial undergoing conservative treatment. So I don't know if this is justifiable with what we know from patients. So if you have a 30, 40-year-old patient with a huge traumatic tear, I think it's not really justifiable from an ethical point of view to undertake him conservative treatment.
They're a different. It's like a fracture. We have to think about. It's something like different.
But I have to point out that this study it's solely on supraspinatus tears. So these are not the large tears. It's supraspinatus tears. Maybe some extension in the subscapularis or infraspinatus, but the mean tear size was 1.5 centimeters, and that is the group we can say these results are valuable for.
Another interesting question asks, have you identified any specific characteristics in patients, that 30% who were sent to surgery after primary rehabilitation?
Yeah, who went to secondary surgery?
Yeah, like age, like traumatic type, like other specifications.
No, of course that would be very interesting. But again, the material is small, and we tried to find, but we couldn't find any differences there. I mean, in this study, in the conservatively treated group, there are two possible results. One result is that the patients are not satisfied with physiotherapy. This were 30%, and then they go to secondary surgery. If this is done early, I think it's an okay procedure, but they have a delayed result because it takes a long time. They have to go through 6 months of physiotherapy, and then they have to be operated. It takes a long time before they finally get their result, and it's also expensive because it has to be paid, both the physiotherapy and the operation. And the other group is the group which is maybe the most difficult one, because these are the patients who do well after physiotherapy. And then you send them out. And now our study shows that after 10 years, these patients are significantly worse than patients who had been operated primarily. But it's really difficult to find out. This is also in this group are, of course, some patients who do very well. And I must also say that these patients, when they come back after 10 years, they are 70, 72 years old. They have a constant score by 65. And I ask them, do you want more treatment? And they tell me, no, I cope with my shoulder. It's not perfect, but I'm now 72 years. It's okay for me. So there's also a danger for overtreatment. If we always think that a 72-year-old patient needs a perfect shoulder. In my practice, I have a look on the shoulder demands of the patients at baseline. Is this a tennis player who wants to play tennis 10 years later? How old is the patient? Is he maybe still working? And this then is a factor for me to tell them, because patients, they ask me, what will happen to my shoulder if it's not repaired? And then I have to tell them, yeah, you get probably, if you have a successful physiotherapy, probably you will end up in 10 years with a result which is somewhat below the surgical result, but it's still much better than your baseline result, because there is improvement also in the physiotherapy group. And then it's a point of discussion with the patient. Do they think that they will do well without an operation and a somewhat lower result on the constant score, or is this a person who needs a top result as good as possible and is willing to go through an operation for that?
Were there any patient after 10, 15 years to go for secondary surgery for not instead of repair an arthroplasty?
We are just now looking on the X-rays to see if there is if there are calf arthropathy or if there are humeral arthrosis. It's very few. Very few. I think I have only 1 or 2 patients in each group developing arthrosis. So this doesn't seem to be a problem. There are patients after 10 years that we could repair. The tear is still repairable, but as I told you, most of them don't want to. And maybe I myself don't want to, because then they are 70, 75 years old, and I mean the prognosis for healing is reduced.
And we know from your other study that after 8.8 years, 50% of conservative treated patients actually ended up with an irreparable tear. So I think these are all very valuable information which you can tell the patient on the day you see them, and whatever they then decide, but now we have some data to really tell them, most likely your shoulder will end up 80 points if you operate on, 60 points if you don't operate on. And we know that after this time period, after 8 years, you have a 50% likelihood that this shoulder or this tear will not be repaired anymore. And we might do tendon transfer, or if you're a little older, you might undergo arthroplasty. But I think it's very valuable to tell the patient. It's not like sometimes, I don't know what will happen. You can do this or that.
Yeah.
You can quite precisely tell them what the odds are, what the chances are. Although there are still some patients, especially if you treat them conservatively, which you don't know which one will do worse. The main group of patients actually end up with the 60 points. And
I mean, this was the reason for making so long period of controls. Normally, I thought I will stop the study after 5 years, but I got always this question: what will happen to my shoulder if it's not repaired? So I thought we have to find an answer for that. So now we have at least 1 study, and I really hope that there are several studies coming, because I mean 1 study is not enough. We should have several studies showing on this problem.
Thank you, Stefan.
There's another interesting question which is related. Sorry, but I always discuss with my patients too. Christina asks, would you propose the primary repair also to a young patient who is not painful at the time you see him in the clinic? But this is not a situation, because the patient doesn't go to clinic without pain.
Yeah, but they can come and they have had some pain and now they are pain-free. No, I don't want to operate on a pain-free patient. But if it's a young patient and he or she has a tear, let's say a 2 centimeter tear, I would like to see her again. I would like to see her again after some, maybe 1 or 2 years. And I would tell her very clearly, if the day you get pain in your shoulder, you have to go to your doctor. Don't wait.
Let me congratulate Stefan, because this is an excellent study, and I'm together with Karl, because I was a little bit worried when I read your previous papers telling us that we probably shouldn't operate anymore, and I'm very happy seeing your results now, because my work is somehow, if it has some reason to do so. If you would like, we are happy to have you with SECEC in the SECEC community, so you can join our international community. If you are under the age of 35, you can join for free because this is our junior free membership. And then you can join in the next year to our society with 2024's rate. And if you do that, you will have an access for the JSS International, and you will be able to find all of those papers that you heard today, and also all the other papers that were presented in the in this year's Congress in Munich. Atachan, I think you should say goodbye.
Yeah, thank you. Thank you very much for joining us, Dr. Elisa Cassart and Dr. Stefan Moosmayer, and congratulations again for their best paper prizes. And I would like to thank especially Karl. He has given a very nice comments during his very busy period of works. I would like to thank Gabor as the Education Committee Chair. And thank you very much for joining us, all our attendees. Thank you.